Hi everyone, welcome to OrthoVirginia's Facebook Live. My name is Dr. Meghpara. I'm one of the orthopedic hip and knee surgeons here at OrthoVirginia. I'm based out of the Alexandria and the McLean offices. And today I'm going to be talking about the anterior total hip replacement. So a little bit about myself. I grew up in California. I went to college out there at UCLA. And then after that, I moved out to the East Coast and went to med school in Boston at Tufts. And then after that, I moved down to Philly, where I did my orthopedic training at the Rothman Institute. And after that, I did a fellowship when moving back to Boston at Harvard at the Massachusetts General Hospital. And I did my fellowship in adult hip and knee replacements, and I specifically chose to go there, primarily due to the complexity of the cases that they were getting, and also to focus a little bit more on the newer technology and some of the robotics as well. So through this talk today, what I want to do is I want to talk a little bit more about hip arthritis and some of the treatment options, and go over some of the basics of the anterior total hip replacement. And then also talk a little bit about some of the benefits of this approach and what are some of the role of modern technology in hip replacements, but also in the anterior approach. And then I'm happy to answer any questions afterwards, and I want everyone to walk away with all their questions answered. So a little bit about hip arthritis. A healthy hip is a hip that has smooth cartilage surrounding it, and it has smooth motion with no pain and has complete range of motion. And over time, with increased wear and increased activity, this cartilage can start to wear down. And rather than having this smooth ball in the socket, you have these pockets of worn down cartilage that have bone kind of grinding against bone, and it leads to pain, stiffness, and prevents you from doing the things you enjoy doing. Arthritis itself can affect many different people. It affects close to 50 million Americans. And when people are diagnosed with this, the first step is to modify the activities, which is not the best option, because I don't want you to not do the things you enjoy doing, moving around the house, playing with your grandkids, playing sports like tennis, staying active in the gym. Those are very important things. Then we start talking about modifying your activity or modifying the medications that you're taking with anti-inflammatories like Tylenol or Advil, maybe even starting some therapy to strengthen the muscles around your hip. Then we offer things like injections, which don't have the best efficacy, but they do provide temporary relief. And then after all of those stop providing any relief and don't really give any significant improvement, then we start talking about surgery. And surgery itself is a very good option. It's one of the most successful surgeries we do, and it allows us to be able to get you back to the things you enjoy doing. So a little bit about a total hip replacement. What it does is it replaces the ball in the socket, allowing you to have that smooth, pain-free motion. And what we do is we essentially remove the arthritic surface. We remove that arthritic ball. And so then you're left with basically a femur where we have removed the ball. We use a titanium stem that we put into the bone and then put a ceramic head on top of that stem. Then for the pelvis, we use a titanium socket that gets wedged into the bone with a plastic liner. We then have both of these components, and now you have a smooth articulating surface here and a ceramic head with a plastic liner that serves as your new cartilage. So we can go to the next slide. And so talking about approaches, it's a very unique thing, specifically with total hip replacements, and no other surgery really does this as much as we have done with the hip replacements. And it's important to know that it's the same implant that goes into the hip. It's just a different way of getting to the hip joint itself. In the long term, I want to emphasize that the outcomes are the same. The most important factor is that the surgeon is comfortable performing the procedure, and a little bit about the differences between the two in terms of how you get to the hip joint. So for the posterior hip, you essentially cut through the gluteus maximus muscle and you peel off these small external rotators at the back of the hip. And these are all small hip stabilizers, but you do peel them off to basically get to the hip. And you do repair these at the end of it, so it's not like they're left free and not repaired. The anterior approach, on the other hand, utilizes an interval between the muscles, and it basically pushes these apart, as you can see on the picture below, and no muscles are cut to perform this surgery. And so my belief is that both of these do have great outcomes in the long run. My personal goal is to get you back to those activities sooner and faster. And I think by using the anterior approach, as I'll talk about in a little bit, allows me to do that better. And we can go to the next slide. So when we compare the two approaches, the direct anterior approach utilizes a smaller incision, and by not cutting any muscles, has a smaller surgical footprint. And that ultimately leads to earlier ambulation and thus a faster recovery. And by preserving the muscles and the soft tissues, patients usually require fewer pain medications because they're having less pain. And since we're not having to repair any muscles, there's usually no precautions associated with the anterior approach, which helps expedite the recovery. It leads to less limp and ultimately better ambulation. That leads to faster independence and faster ability for you to return back to your activities. And so what I want to do is I want to go through some of the modern technology and some of the modern advancements and show how they address the traditional complications associated with hip replacements, and how these advancements are even better sometimes when utilized with the anterior approach. So one of the most common complications associated with any hip replacement is a leg length discrepancy, meaning your leg lengths are different lengths after the surgery. And so with the anterior approach, the specific table that we use allows us to utilize X-ray. And it's also the fact that you're positioned when you're laying flat allows us to use X-rays intraoperatively, which is a very, very powerful tool. So during the surgery, we're able to measure the leg lengths to know that the implants are positioned in the right spot, and that we're putting everything and balancing everything out with your leg lengths. And there's a lot of new technology that's even utilizing AI to account for the distortion that's associated with X-rays. And then another common complication with any sort of hip replacement is dislocation. And this is because your pelvis tends to change position when you sit, when you stand, and when you lay down. And so when we have our hip over here, basically when you stand, your pelvis kind of tilts forward. And then when you sit, it tilts backwards. And the spine basically can affect this in many different ways. And it's different from person to person. And by utilizing X-ray in the surgery, you can customize the position of the cup to each person. And that allows me to maximize the function and to minimize the risk of any dislocation happening in the future. And that ultimately is why I don't place many precautions on patients undergoing an anterior total hip replacement. And if we look at the literature, it shows that there's almost a 5 times less risk of dislocation compared to the posterior approach. And another complication, specifically with the anterior approach, is that it has a higher risk of fracture. And this is related to the fact that since you're not removing any of the muscles or cutting anything to get to the hip, you're dealing through a smaller operative window. And traditionally, when you place a stem into the bone, as you can see by the second square, it's a square wedge that goes into a cylindrical structure. And that serves kind of like a log splitter, and any sort of rotational force can lead to a fracture down the bone too, which is a devastating complication. And some of the newer technology and the newer implant designs have a more tapered design that actually fills up the bone, and it has a collar that actually prevents that stem from breaking the bone and actually gives you more rotational stability. And it's the current data shows that there's almost a 10 times less risk of fracture with the utilization of this new implant design. There's also this automated impaction and automated broaching that we can utilize, and it helps that it provides a reliable or bony envelope so that there's less variability and less force that's less variability in the force from the surgeon itself. And it can be intimidating that you're using this kind of like jackhammer like device. And I'll tell everyone that I've actually taken this device into the lab, and on cadaver bone, I've done everything I could, put my whole weight into it, and I've tried to break the bone, and I have not been able to do it. So it basically allows us to accommodate for all sorts of bone quality and to basically have a very good standardized broaching technique when we're putting our stem into the femur. And another question that I often get asked is, how long do these hip replacements last? And classically, they were thought to last anywhere from 15 to 20 years. And now the plastic liner that we put into the cup, they've been redesigned and they've been developed to have very good durability and very good wear resistance. So with this new material and this new design, they're showing that there's almost 94% survivorship up to 20 years. That shows that it can be, last even longer than what we originally thought. And this is allowing us to operate on people at younger ages and allowing us to operate on people rather than having to push surgery off to the point where we feel comfortable that they're not going to require a revision surgery. And so when it comes to recovery, it looks different for everyone and every single person. And I wanted to give a general timeline of what this may look like, but I want to emphasize that when it comes to surgery, I work with every person based on their individual goals, their individual circumstance, to come up with a plan that's specifically right for you. So anywhere from close to 50% of our patients are going home the same day after a hip replacement, but the other half are either requiring 1 or even 2 days in the hospital. Most people are utilizing a walker within the first few weeks after surgery, and then start transitioning between 2 and 4 weeks to utilizing maybe a cane or walking more independently, and start resuming their activities between this time frame too. And usually by 6 months to 12 months, that's when you start kind of increasing your activity and return back to the things you enjoy doing. And most of the times by 1 year, people almost forget that they had a hip replacement. And if we go to the next slide, my goal is that a total hip replacement is a very, very powerful surgery. And it has the potential for you to get back to doing those activities that you previously were able to, but now are limited to because of the pain. And so with that being said, I'm happy to answer any questions and would love to chat more about this.
Thank you so much, Dr. Meghpara. So we will be answering questions submitted earlier and questions submitted live. Not all questions will be able to be answered, but we will do our best. If you are watching live, please feel free to put your questions in the comments now. So our first question is this surgery for everyone?
This surgery is good for a majority of people. Most of the people that have hip arthritis can undergo a direct anterior total hip replacements. There's 2 primary things that would prevent an individual from having that. The first is if you have a very complex deformity, meaning that there is significant amount of bone loss from injury in the past or from dysplasia as a kid that requires a more aggressive implant or a more extensive dissection. Those are often difficult to do anteriorly. And the other thing that I do watch out for is for people with a little bit more weight, have a large belly. And a lot of times that fold can have skin that's very prone to infection and kind of gross, but it can often develop fungus there. And when patients are high risk for infection, I tend not to do this surgery because an infection with a hip replacement is a truly devastating and a life-changing complication. And I would not want that for anyone.
Thank you. Is physical therapy needed after an anterior approach?
So for my patients, physical therapy, I don't have patients enroll in physical therapy for the first 2 weeks. And my main goal is that you're ambulating essentially every day, once an hour, every hour if possible. At the 2-week visit, when I have you come into the office for x-rays and to look at your incision, if you are struggling a little bit and need a little bit of assistance and supervised therapy, that's the time I decide to have a patient go through with physical therapy. But it's not required, so to speak.
Thank you. Someone asks, if I had a previous surgery to repair the labrum, will that be a problem?
No, that won't be a problem at all. It's actually a very common thing that we do see and does not change our protocol in any way.
Thank you. Can you have a hip replacement if you have osteoporosis? And if you do have osteoporosis and you can have a hip replacement, is anything different about it?
Yes, that's a very good question. You can have a hip replacement if you have osteoporosis. And the main thing is, as you get older, your bone quality starts to deteriorate a little bit. And you have less dense bone as you may have had when you were younger. And the previous implants that we talked about, the new implant design is very good at accommodating for people with osteoporosis. But once you reach a certain point in a certain age, usually around between 80 to 85 years old, if the bone quality looks thinner on x-rays, we actually choose to cement a component into, or a stem into place, rather than using the wedge style implant. But it does not affect your recovery in the long run, and it does not change the surgery in any way. It's just how the implant is fixated into the bone.
Thank you. Someone else asks, can I have the anterior approach if I have had a previous hip replacement?
So the answer to that question is it depends. It depends on the type of surgery you're doing to the previous hip replacement. If it's a minor, maybe plastic, changing out the plastic liner, and you had a previous anterior approach, that's perfectly acceptable to do. But if it's something that's a little bit more extensive and the problem is a little bit more involved, oftentimes I would use a posterior approach just to be able to accommodate for the complexity of that problem.
Thank you. How do you know it is time for a hip replacement? Is there something specific on the x-rays, or is it just the amount of pain you have?
So I think there's two components to it. The x-rays should show some sort of wearing of the cartilage, some sort of bone-on-bone articulation, meaning the cartilage is worn down and now the bone is grinding against the bone. But the decision to proceed with surgery is not dependent on the x-rays. It's dependent on you, the patient. So my question that I ask everyone is, how bad is it affecting your daily life? And when it's bothering you so much that you're thinking about it every day, you're losing sleep over it, you're not able to do the things you enjoy doing, and you're willing to go through the recovery process to be able to get back to having a pain-free life, that's when we move forward with surgery. So it's partly due to the x-rays, but mainly it's dependent on when you are ready to go through with it.
Thank you. Are there any issues with activity after recovery? So we've had specific requests about people who are interested doing hiking, dancing, and downhill skiing after a hip replacement?
Yeah, so everyone has different levels of activity, and my goal is to get you back to those activities. So in terms of hiking and dancing and skiing, many times we do get patients back to that activity, and I don't place restrictions on people wanting to return to those activities. The question is, when does that occur? And it depends on the level of activity. The more high impact activities, we usually wait closer to a year. The lower impact activities that don't place too much stress on the hip, we allow that a little bit sooner, closer to 3 to 6 months even. So it depends on the type of activity, the level of activity, but my goal is that I want you to be able to return to those activities. And even if it's a higher demand activity, the main thing that I get worried about is running and long distance running.
Thank you. How do you prepare for surgery? Is there a diet or exercise program to follow?
So preparing for surgery is, I think, just maintaining your activity levels as best you can, as much as the pain allows you to do so. The more strength you have going into surgery means that you're going to have more strength coming out of surgery. So being able to optimize that in whatever way you can tolerate is the best thing for you. And then in terms of diet, the best thing to do is to make sure that before and after surgery is to have a healthy, high protein diet. Those are things that will help your recovery, help you heal, minimize the risk of infection, and help you be able to recover and build back your strength faster afterwards.
Thank you so much, Dr. Meghpara. That is all the questions that we're answering today. Would you like to close?
No, thank you everyone for joining, and I hope everyone learned a lot, and looking forward to meeting all of you soon.